Hello everyone, my name is Dr. Denise, the CEO of Cornwall Cancer Foundation. I would like to welcome you to our Cornwall Cancer Foundation page. Our goal is to create an awareness of the challenges, support and guidance experienced in managing cancer care for sufferers, family, carers and friends. To engage with us, don't forget to subscribe to our channel. Click our notification bell.
Hello everyone, good afternoon. My name is Dr. Denise Ejo. I am the CEO of Cornwall Cancer Foundation. I'd like to welcome you to our new event for April. I think this is April, yes. And we're looking at colorectal cancer. In the house today, we have got Dr. Olubumuyi. Did I get it right, Doc? Olabumuyi. Good. I got it. Eventually. It's very long. So I was thinking it in my head and I was like, I'll get it right. And I knew I'll get it wrong. Okay, so we've got Dr. Olabumuyi on our forum today, and he'll be talking to us about colorectal cancer. Colorectal cancer was at a point in its a rare form of cancer in Africa, and over the years it has become the third largest killers of cancer in Africa. So today we want to talk about it, and I think I do know quite a few people who have gone through some form of colorectal cancer. Some have made it, some have not. Let us keep the space open. Let us listen, let us share, and as much as possible, can we share information with our friends and families who have or are going through cancer at the end of this. So I want to welcome everybody to this event, and I will be handing over to Doc. He is a consultant in university. See, the reason I'm not going to read the whole title is because I will not get it right. I keep trying every time, and you people's medical terms are just tongue twisting. He's a medical consultant at the University of Ibadan. He was very hard to get. I had to try twice before I could get him on. Yes, you were. So you may not know. Today I'm going to say it. Very hard to get. But thank you very much for joining us today. We hope we all have a nice time together, and we have a lot of questions as we go along. Okay. The floor is now yours. I will switch off my mic.
Thank you very much. As Dr. A just said, my name is Niyi. I'm a consultant oncologist at University College Hospital in Ibadan. I'm sorry for being hard to get. The initial try was a bit short notice, and I had family engagements then, but I've kept my promise today. I'll be sharing my screen because I have a slide that I'd like to, but I think the host has disabled screen sharing. So you can enable that. It's still saying that the host has disabled screen sharing. There's a green button down. So yeah, you're muted, so I can't hear what you're saying.
Sorry.
So there's a green share screen button down on your screen if you're the host. So beside that green button, you see a small arrow. So if you click on
the one that says share.
The one that says share, you see a smaller arrow beside it.
Yeah, I've shared it for you. Multiple participants can share. I've shared it for you.
Okay, thank you very much. Thank you very much.
Can you see yourself now?
Yes, I can. Hold on. Sorry. Okay. So cancers, just to keep it simple, colorectal cancer is any group of cancers that affect the colon and the rectum. They're actually distinct. There's colonic cancer and rectal cancer, but the colon and the rectum are a continuum, and their risk factors and treatments are so similar. So oncologists and people just generally call them colorectal cancers. But I would like to talk about cancer in general, just to define the term for us to understand what we are talking about as it applies to colorectal cancer. So, a cancer is an uncontrolled and uncoordinated abnormal growth of cells. Now, the reason why we are this size, we've grown so much from when we were born as babies up to right now, is because cells divide and grow. So, we don't have any problem with cells dividing and growing. It becomes a problem when the growth is abnormal and uncoordinated and out of sync with the entire human body. So when one has such an uncontrolled and uncoordinated abnormal growth of cells, which also has the capacity to invade nearby tissues and organs, and not only that, it has the capacity to spread to distant organs, and that's a cancer. And if no treatment is offered, this abnormal growth will ultimately lead to the demise or death of the individual. That's cancer in brief. Now, this, when it occurs in the colon and rectum, is colorectal cancer. So, in the US, most of our data comes from the US. We have our own data too, but a lot of oncologists quote the US data because they drive data in oncology. So, permit me to just use some of the data from the US. So, 1 in 21 men in the US are affected by colorectal cancer, 1 in 23 women in the US too. It's the second leading cause of cancer death in women and third in men in the United States. However, due to screening techniques and improvements in the treatment, death rates from colorectal cancer is falling in the US. In Nigeria, it was estimated to be the fourth highest cause of cancer, with an estimated 7,478 new cases in last year, but also estimated to have the same fourth highest cause of cancer deaths in Nigeria, with an estimated 5,399 deaths last year. Now, you see these figures, well, once the death rate is close to the incidence rate, it means that cancer is more of a killer than another cancer. Take breast cancer, for instance. Breast has an incidence of about 20,000 in Nigeria, but a mortality rate, a death rate of about half of that, which means people tend to survive breast more longer than colorectal cancer. So that's something we need to just bear in mind that in terms of being able to survive it, compared to breast, colorectal is much more difficult to control. So its symptoms of colorectal cancer would include something lingering for a while. The person might just have fatigue or tiredness because of anemia, because they might just be losing blood through the stool. There'll be some altered coloration of the stool if it's in the distant side of the colon. The stool will just change in color due to the blood. But if it's in towards the end, towards near the anus, then there'll be frank bleeding. Then there might be changes of bowel habits, like more diarrhea, difficulties in passing stool, constipation, a lump on the abdomen, or dietary stools. Then some patients might just have unexplained weight loss or abdominal pain or bloating or a feeling of fullness. We've gone through most of these symptoms in the previous slide. So whenever a man has anemia and is told that it's iron deficiency is the cause of anemia, one of the things here one has to think about is could it be colorectal cancer? Women, except if they are menopausal, because women tend to have monthly blood losses through their menstrual periods. We don't think of colorectal cancer when women in their reproductive years have iron deficiency anemia. But when they're postmenopausal and the diagnosis of iron deficiency anemia is made, one needs to look at that could it be colorectal cancer that is causing this, because the blood loss from the stool is something that will be ongoing and may not be noticed on time, especially in the right side of the colon. So the risk factors when it comes to cancer, unlike infectious diseases and other kinds of diseases, we usually say etiologies or causative agents. But with cancer, we don't really have causative agents per se, but we just have factors that increase the risk of cancer. So and those risk factors can be divided into the ones that can be modified or that can be changed, and the ones that cannot be changed. So first of all, starting with risk factors that can be changed. We notice that patients who are overweight or obese tend to have are more susceptible to developing colorectal cancer. Then people who are not physically active and don't exercise so much tend to have tend to have more cancers in general, especially colorectal cancer. Then the following diets are noticed to be have a high to tend to lead to colorectal cancer, such as red meats like pork, beef, lamb, liver, and processed meats like hot dogs, and patients who have low blood level of vitamins such as vitamin D and vitamin C. And smoking is also a risk factor of not only lung cancer but many other cancers, including colorectal cancer, cervical cancer, breast cancer. Then alcohol use, especially when it's moderate to heavy, also is also one of the risk factors of colorectal cancer. Now, there are some risk factors that cannot be changed. Well, you can't change your age, but it's noted that the older one gets, the certain cancers like colorectal cancer are found more among the people that are above the age of 40. Then people who have had a personal history of some benign form of tumor in their colorectal region, previous polyp, because polyps tend to add, actually when cancers start, they initially start as polyps, then they can then progress to cancers, but not all polyps are cancers. So anybody who has a personal history or a previous history of a polyp should be surveilled more, should have screening more, so that just in case that patient now gets a cancer or develops a cancer. So if, people who have some form of inflammatory bowel disease like Crohn's disease and ulcerative colitis, they tend to have cancers more frequently or colorectal cancers more readily than other people who do not. Then patients who have a family history of colorectal cancer too. There are people who have some form of genetic inheritances like Lynch syndrome, familial adenomatous polyposis. But anyway, there's some inherited syndromes that makes them more susceptible to developing cancer. And these genetic symptoms tend to develop more earlier. So when you see colorectal cancer in the young, like teenage years or before the age of 30, it's the patient has a genetic inheritance syndrome. And it's found out that African Americans in the US tend to have more incidences of breast cancer or colorectal cancer compared to the non-African Americans, and that should translate to Africans too because we have similar genes. Then also Ashkenazi Jews too. So when it comes to cancer, just as I said, when it comes to cause, we don't have causes in cancer. We usually have more risk factors. So also prevention is not certain, but it can go a long way to reduce one's risk of developing cancer. So there's some preventive modalities that one can do to to reduce one's risk of developing colorectal cancer. One of them is to modify the risk factors. So all those risk factors I mentioned that are changeable, that can be changed, one should adopt positive change, like exercising more frequently, having a diet that is rich in fruits, vegetables, and whole grains, limiting red or processed meats, and limiting or avoiding drinks that are high in fizzy content and sugary content. Then one can also try as much as possible to stop absolutely smoking and then to reduce alcohol consumption to less than 2 drinks per day for men, less than 1 drink per day for women. Then screening. There are screening modalities for colorectal cancer. And screening helps to discover precancerous conditions before they become cancerous. Like those polyps, screening helps to discover polyps while they are still benign before they become malignant. And it also can detect cancers at early times when they are more readily curable. I have this theory for cancer that I call the um, vagabond child theory that helps to get an analogy for us to understand cancers. So a vagabond child will initially cause problems within his home, within his house. His mother and parents and siblings will not just like that. He'll be causing terrible commotion within the house. If nothing is done, that vagabond child will then start causing problems in the streets. And if no intervention is done, that vagabond child will now start causing problems in the neighborhood. And then thereafter, it now becomes a situation where the parents will be seeing the child in network news saying that he's caught for some national crime. So that's how cancer 2 progresses from stage 1 to stage 4. Initially at stage 1, um, it's just located in the organ of origin. By the time stage 2, it starts to affect nearby organs or regional organs. Then eventually stage 4, it begins to spread to distant regions. So just like that vagabond child, the earliest time to have intervened was when he was just causing problems at home. Once it starts to get to the point where we are seeing the child as an adult on network news with a story that is coming to the end, at that point in time, maybe the only intervention that can be done is prayer. And that's almost similar for stage 4 cancer. Medical, I'm not saying there's no medical intervention. To aim for cure is difficult at stage 4, but one can aim for cure at stage 1. So that's my vagabond child story for understanding cancer. So screening helps to detect that vagabond child at home. So that's one of the things that screening does. It discovers precancerous conditions before they become cancerous. It also detects cancers at times when they are more curable. So some of the screening modalities for colorectal cancer include stool-based tests, like the highly sensitive fecal immunochemical test, which should be done annually once one gets beyond the age of 45. There's a highly sensitive white-based fecal occult blood test that should be done also annually once one gets beyond the age of 45. There are also some DNA tests because the previous 2 tests I mentioned are tests for blood. So anything that can cause bleeding in the stool or some form of blood in the stool will make those tests positive. And colorectal cancer is not the only thing that causes bleeding. But we know that colorectal cancer starts with bleeding, and so it's a good test. But the issue with that's why this multi-targeted stool DNA test will detect DNA in the cells of the lining of the epithelium that are in the stool that are likely cancerous. So it's more specific or more targeted towards cancer. The previous 2 tests are good tests that could be done that will detect bleeding, minimal bleeding, minute, unnoticeable asymptomatic bleeding that could now make one to now do further testing to know what is causing the bleeding. There are also some visual examinations or visual testing of the colon and rectum, like a colonoscopy, which should be done every 10 years after the age of 45. And there's the minimal or non-invasive scopy that is done through a CT scan called a CT colonography. So it's a virtual colonoscopy that's recommended to be done every 5 years, or a flexible sigmoidoscopy. Now, the sigmoid colon is the terminal end of the colon. So it's not an extensive colonoscopy, it's just its terminal end. So that too can be directly viewed called the sigmoidoscopy and should be done every 5 years. Now, all these frequencies I mentioned, starting from the previous slide, are applicable to people who have normal population with normal risk factors, or not increased risk factors. But those people who have family members that have breast cancer or colorectal cancer, people who have had polyps in the past, people who have done genetic tests and know that they have a genetic syndrome, rendering them susceptible to colon cancer. In them, the screening should start earlier. There are some that the screening should even start in their teenage years. And then the screening should also be done more frequently, maybe where you have a 5 year, it to be 2 years or annually. So more frequent screening and earlier screening should be done in people who are at increased risk. Now I'll take this time to talk about national screening versus personal screening. So in this gathering, there might be people who are either in government or connected to government or can effect change for the better one way or the other outside medical. It may not necessarily for cancer, it's a holistic approach, not just the medical approach or research that contributes to change. Sometimes policy, NGOs like what Dr. Ejo are doing. Can I continue? Can I continue?
Yes, please.
Okay.
Yes,
So
you can.
that The approach to cancer care for a nation or a community should not just be limited to patients and their doctors. The family members that have to gather around the patients are also part of the approach. The policymakers, elders, traditional rulers, senators, and all that are part of the approach too. So I want to talk about national screening versus personal screening. So for national screening, it's over time we have realized that if you are screening is like a low hanging fruit, it's easy to start saying, okay, men come and start doing PSAs, women start doing mammograms, um, people start testing your stool for blood. It's almost like a low hanging fruit, higher spectrum of cancer care. And so it almost seems that there's a lot of efforts in especially low and middle income countries to get people to screen. But we have realized that screening is almost like having a CCTV in your shop or in your church or in your home. So if you have a CCTV in your house, if somebody comes and robs the house, you'll be able to see a video of the person robbing the house. But if you don't have security guards and then liaising with the National Police Force and all that, that's a big way. And every day, what you just be doing is shooting the video and seeing that the person that stole my laptop. And every day, all you have is just one CD that tells you that this is when the person has taken the laptop. But that person has taken that laptop and that person has gone. So that's the way that's kind of thinking screening. That nations should first of all set up and beef up their capacity to treat cancers. Regionally, they should let's use Nigeria that sits geopolitical regions in the country. All six geopolitical regions have very, very good cancer centers to start with. And then we can now have a national screening modality so that once you detect a cancer in a citizen of that country, there are steps to be followed. However, what we have right now is, people will be able to say, yes, but okay, the tracking machines that are working before are broken down. But now they're no more broken down, they're working. There's PPP, but it's very expensive for the population. So what I'm saying is that in national screening, we should first of all do what we call national capacity building for cancer care across the whole continuum from diagnosis to treatment and then to palliative care. But for personal screening, like this is an individual, uh, it also keys into national screening. So if an individual is living in a country where they have a good national screening already, it's easy to do personal screening because the nation will make that person to screen personally. And then those nations tend to have good preventive medicine modalities, insurance, and all that. So they want you to detect the cancer early because it will save them taxpayers' money. But in other countries where the payment for healthcare is out of pocket, in those kind of situations, the government is not entirely responsible for your healthcare. And so well, now the onus now lies on the individual to do that screening. And so for that, for individuals, I'll say, okay, well, for what is what, embrace all the screening modalities that people are advancing, either in church or in NGO or in hospitals. Embrace it. It's good to know that if there's something there, it's good to know it early. But then the issue now comes with what do you now do after the screening detects that there's something there? What do you now do after? And all these things go back to the whole nation as a whole. Where is health insurance? Because out of pocket payment is not very, very easy for everybody to do. And thinking holistically, that's the reason why I actually just mentioned this slide, just to let us to think about the fact that cancer needs to be approached holistically. Thank you very much. So in terms of treatment of colorectal cancer, there's the modality that tends to ensure cure is surgery. Now, surgery is not the only modality, but if it's seen early and but the bulk of the tumor can be taken out, and then that increases the chances of curing. So the modality of treatment that leads to a higher chance of cure is surgery. And the type of surgery is done, it depends on the location and the stage. If it's in the rectum, they want to do no anterior resection or an AP resection. If it's in the primary modularly in the colon, you can do a hemicolectomy. That means half of the colon or part of the colon is taken out and then rejoined. And there'll be need for a colostomy. This colostomy could be temporary, where they can rejoin later after they've taken out the cancer. But if it's towards the end of the near the anus, and then control of the continents is not going to be achievable, then they might just remove everything towards the end, and then there'll be a permanent colostomy. So even the colostomy bag and taking care of that comes with its own challenges too. The other modalities of treatment include combination chemotherapy using traditional cytotoxic agents or targeted therapy, which we talked about. It tends to be very expensive. Like the Avastin is expensive, and that's another thing that's happening in the country where you have people that cannot afford the Avastin because it's just cost maybe over 200,000 naira, and you won't have to take it 2 months and 2 weekly or 3 weekly. So there are holistic issues at the policy level that needs to come in for a greater proportion of the citizens in the country to be good cancer care, especially colorectal cancer. Then the next modality is radiotherapy too. And in terms of what the International Atomic Energy Agency states is that there should be one radiotherapy machine for 250,000 citizens. So colloquially, we usually state that the population of Nigeria is about 200 million. So if you multiply that, the 200 of the 200 million by 4 is 800. So really, according to IAEA standards, we should have about 800 radiotherapy machines in Nigeria based on our population. But right now, we hardly have 6 working. And sometimes it's on and off periods. Then 2 out of those 6 that are working are new, and so they are very expensive. There's also public-private partnership involvement, so there's very expensive. So we have a situation where there's machines in Lagos, but people in Lagos come to Ibadan for treatment because they can't afford the cost of the machine in Lagos. So those are some economic issues also come to play in the treatment of cancer generally, even colorectal cancer. So after treatment, and if the patient does well, and we usually want the patients to do well, then we go into the surveillance or follow-up aspect of management. Those routine checks are done, and the routine checks involve the history taking and physical examination to look out for red signs or red flags. And then some of the images we spoke about in screening will also be done, like colonoscopy or spectroscopy, CT scans, and then routine blood tests. So it depends on the patients and the doctors and what they see that determines the frequency. But usually there could be 3 monthly for a period of time, about 2 years. Then after 2 years, 6 monthly for additional 3 years. Then annually thereafter. So once there's 5 years post treatment, usually most patients are now moved to the annual follow-up, annual checkups. I think that's the last slide. So thank you for your attention. Any questions, comments, or clarifications? Okay.
Thank you, Dr. Niyi. Interesting. I was looking through, I was trying to work through some of the facts you raised here, and it's interesting. Please, if anybody has any questions, you can put up your hand. Doc, do we want to come down? Do we want to bring down your slide? Okay. So if you have any questions, we can you can either put up your hand or send the question through, and I'll read it out. One of the things that was very interesting that I observed was your statement that you said vitamin C and vitamin D. Vitamin D came into public knowledge very seriously in COVID, because a lot of us that don't take vitamin D, we learned to take vitamin D, and now it's vitamin D. Anybody that doesn't take it or hasn't got the hang of that revelation, I think I just heard it again, but it's interesting. And the statement you made about the holistic approach, wow, that is a big one for us as Nigerian citizens and how we can contribute to that. But let me start to take the questions. Those are 2 things I really picked up on. I was like, wow, okay. So firstly, I got a question.
Can I respond? So the
Yeah, you can. Okay, yes, please.
so now some of those statements on the nutrition are on the probably, they are on the probably region, not on the definitely region. Even with their science and the data, most people say probably, in the sense that it's not so, it shouldn't be taken as a cure. It shouldn't be seen as a
Oh no,
cure.
no, no. Yeah.
So even so, yes, it's something that, and then also in terms of the vitamin D's metabolism, sunshine, exposure to sunlight has its effect. So I'm not too sure I'm going to recommend it as something that, okay, everybody start taking vitamin D right now. So it's just some form of information out there.
Oh no, I only brought up that vitamin D because for us in England, we had a lot of understanding this vitamin D, and the weather and the lighting is not. So we're not in summertime, so I think all of us should be using the sunshine to get this. There's a question here for you. Thank you. Can you still have a meaningful life, quality of life after treatment of colorectal cancer? Thank you
Yes.
for that question.
Should I go ahead and answer?
Yeah.
Okay, so my answer to that is yes. My answer to that is yes. And well, yes, to a degree. First of all, what's the definition of full quality of life or full meaningful life? So that's another thing. How do you define what a full life is? Now, if you mean life that is similar to how it was before the diagnosis, the answer is still yes. But for the answer to be yes, like one has to improve upon certain things. It has to be this regular screening so that so that cancer can be detected early. The earlier the cancer is detected, the better the treatment and the more the probability of achieving a cure from the treatment. Now, even after a treatment, some treatments have side effects. Now, but side effects can be managed. And then, if I want to balance everything, having cancer compared to not having cancer but having side effects of treatment, I'm sure most people would choose not having cancer but having side effects of treatment. So I would say yes. It's not a straightforward yes. It's a yes with terms and conditions, providing there's good screening, providing the cancer is found early, providing good treatment is affordable and available, and the person gets the good treatment. Yes, it's possible for one to have a good quality of life afterwards. Then also, even if the patient is seen late, the patient is seen late or in metastatic situations and circumstances. Well, the question then is, would one need to shift the goals post? Would one need to shift the goal post on what the definition of a good life is in that hospital situation? Let me just go to extreme. Maybe somebody was thinking of climbing Mount Everest. That was his plan. I climb Mount Everest, God take me to heaven, I'm done. Okay. Once I can climb Mount Everest, I'm done with living. I can go to heaven. I've survived myself. And everybody has their own Mount Everest. It could be I see your daughter getting married. It could be getting a PhD. But everybody has their own Mount Everest. And suddenly, that person, his legs are chopped off. He got into a ghastly motor accident. That person might have to evolve and say, okay, I can't climb Mount Everest anymore, but can I just be there for my son and be a good father to him? Maybe that would be the next thing to climb Mount Everest. Right now, it's just so. Sometimes one has to shift the goals from what one thought a good quality of life is before he had cancer to what a good quality of life is after. But even that after period, it comes with good treatment, and if it's not curable, it comes with good palliative care. So the answer is yes.
Sorry for the first time. I don't know what to say, but yes, yes. But that means that I'm trying to process this, right? And for those of you that have not met me before, my name is Denise Ejo. I have already introduced myself, and I live with cancer. That's how we call it, living with cancer. Now, um, the answer is yes. And the answer is we need to, well, fundamentally, we need to have a very positive mental mindset in conjunction with the diagnosis to be able to get through the ups and downs using your statement of the example of climbing Mount Everest and your terms or your goals change or your ambitions change, which I will stand and say that is spot on. Anybody that hasn't got that vision and so you have found yourself with cancer, that is spot on. The goalposts will change. So I fundamentally agree with you because the goalposts change for me. However, in the same conversation, I would also agree with you on the fact that to a level, there is still a very good quality of life, because now I'm talking about it from a survivor's point of view, because that's what I call it. Apparently in Nigeria, we're called survivors. In England, that we're called living with cancer. Whichever way it's called, it doesn't really matter. I just have to live. Yeah? Okay. The next one is the fact that if we have to go through it, and you see the metastasis, I don't know if that's how they pronounce it, but metastasis, colon cancer on its own, without a metastasis, is it common to have colon cancer on its own without a metastasis, or do you get colon cancer with the metastasis?
Is that a question?
Yes, yes.
Okay, so when I was defining cancer,
Yeah.
cancer is an uncontrolled, uncoordinated groups of cells that can invade. I mean, it's really colon, but it can invade something nearby, maybe the line of the colon or some other thing near the colon. But then it can also spread to distant organs. Now, that spread to distant organs is called metastasis. You understand? And so, one of the hallmark of cancer, what actually defines that this is cancer, is the fact that it can spread to distant organs. So yes, now in communities or countries where there isn't any national screening plan, then you have a situation where the patients will be coming at advanced stages. Now, the patients come at advanced stages, that means they will be coming with metastasis. And usually, primarily, the organ that colon cancer spreads to the most is the liver. So there will be a lot of patients that will come in with newly diagnosed colon cancer, but it has already spread to the liver. Yeah, so yes, it's possible. That's why it's cancer. That there are patients that are diagnosed with colon cancer, but it has already spread. We want to get that to as low as possible by encouraging a national policy or screening modalities at the individual level, but even better at the national level. And we also want to encourage not just screening it and noticing that okay, this is cancer, but to be able to treat it.
Thank you. If you have any questions, please just put up your hand and press the, what do you call it, the reactions, and I will put it on. I've got a question here that says, what is the major side effect of radiotherapy on the brain of a metastasized colon cancer? Does that make sense?
The radiotherapy to where? Like, where's the radiotherapy being treated? Is it where the colon?
Can I see if the person is on? Can I put your hand up for you to speak, or you don't want to? It's.
Who is it? Okay.
Okay. Go on.
Okay. My question is, what's the effect of radiotherapy on the brain? It's metastasized colon cancer. The primary cancer is colon cancer, but it's metastasized on the brain. And it's being treated, the lesion on the brain is being treated with radiotherapy. So I'm asking, what is the side effect?
Okay, Doc.
All right, thank you very much. So one the major side effects is that the brain can swell. But we already know that as oncologists. And so radiotherapy, we place the patients on drugs that will prevent the brain from swelling, so that the brain is covered by a hard casing, the skull. So if something swells in that hard casing, it can cause more issues than even the tumor that is spread there. So to start with, any patient that is on radiotherapy, we place the patient on steroids to prevent that swelling. That's one. Two, some patients tend to have what we call somnolence. They sleep a little bit more. Um, in children, it might affect capacity for the cognition. So this grades in school might be affected, but that's transient and they're able to cope better. But in adults, the brain functioning has already reached its cognitive capacity, and so it doesn't really have effect in cognition in adults. However, more often than not, most patients get to have to receive radiotherapy to their brain without any significant life-altering side effects. And then with anything cancer, there's a risk-benefit analysis. There's the side effects that come from radiation on one hand, and there's also the effect of not treating the cancer and leaving it there in the brain. So with the risk-benefit analysis, usually the balance swings in favor of treating it.
Thank you. I think, does that answer your question? Let me go on to another one I have. And if you have your questions, or put up your hand and we'll take it from here. The next question I have. The next question I have now is, when colon cancer primarily is, like you described at the beginning, is the ones in the colon, right? And you said rectum. But then you also said it has an effect for men and women. The survival rates in the presentation, we were talking about the different survival rates and stuff. When we narrow it down to Nigeria, because at the end of the day, most of us on this platform we live or work either overseas or Nigeria. But if we wanted to do something to make a difference, can you give us 3 things that can be campaign? Because a lot of the time we always hear pay for treatment or do fund this or fund that, but one of the disheartening things is that the fundraising platforms have been abused, which is something we're very used to. So making sure that it's targeted to reach the right people with this kind of treatment, because I can tell you for a fact that I know at least 5 people who have gone through it, and to be honest, Common Cancer Foundation started last year. It's not even up to a year, and it's been online. But when I sit and have to listen to what the challenges they all went through and where they are or not, what is it that could have changed? Does that make sense?
It does. Okay, so let me just assume I have a magic wand that I can use to say, let me this and let me that. So one of the things I would like to do is that, as I said, in all the 6 regions of the country, there should be at least one cancer center that has everything from screening to diagnosis to treatment. By everything, I mean, yes, good screening, capacity, and that screening is not just the infrastructure in the hospital, but also other things like being able to follow up patients, IT, calling patients, sending them text messages. So right now we have the NCDC that keeps on sending us messages to our phones, giving us messages about COVID-19. So if that can be adopted to sending messages to raise awareness of cancers generally, that is the top 5 cancers in terms of incidence, good. It can also be adopted to let people to send reminders to people to say, okay, in the next 2 weeks, you should be coming for a fecal occult blood test and all that. So screening, diagnosis, then also all the modalities of treatment in terms of in those centers, we have good surgeons with fully trained surgical oncologists, radiation oncology with state-of-the-art equipment or close to state-of-the-art equipment, and also chemotherapy. I would like most forms of chemotherapy, including the most expensive targeted therapy, to be on the National Health Insurance Scheme. All those could be on the National Health Insurance Scheme, and so patients don't have to pay out of pocket for all those drugs that cost a lot of money. Anyway, chemotherapy drugs range from something like 50,000 to 500,000. So sometimes some patients are just excluded from treatment based on the fact that they can't afford it, and that's kind of sad sometimes. So if that can be done, then I would now want a good national screening policy or plan for all individuals above the age of above a certain age to enter into the screening program for breast cancer for women, prostate cancer to an extent, even though Western countries are really to scale back for prostate. But for us, maybe until we see the indices they saw, I was prostate there and the colorectal cancer. So those are the major two things I would like to see done. That would lead to if chemotherapy can be changed from out of pocket payments to being an insurance scheme, they are available radiotherapy and also being on the insurance scheme paid for by taxpayers' money, then you would see it, and then with more information and surveillance and screening, then you see the numbers. The numbers might not reduce in terms of incidence, but the numbers of mortalities and other statistics that indicate that we don't have the capacity to treat, those numbers will get better.
Thank you. At least I'm fortunate to be on the platform for the Nigerian, I think it's how they call it, NSC, and I'm sure you're on it as well. And I do know for a fact that President Dr. Umar has been doing a lot of work fighting for at least the equity balance on cancer care, cancer treatment for under the National Insurance Scheme, right? I think we have to be very. I think I am, at least I want to say I am aware. I don't know if he's online, if he wants to share that, but I do know.
I actually must say that we've come a long way in a short time. Even within 5 years. Within 5 years, I noticed chemotherapy, most generic chemotherapy drugs were placed on the National Health Insurance Scheme. I think they are beginning to put radiotherapy in the National Health Insurance Scheme. But targeted therapy is not yet on it. And then also another thing about the National Health Insurance Scheme is that coverage, in terms of coverage, is still quite limited to civil servants and government workers. Now there's efforts, I must say, to expand the coverage to include the non-formal sector by trade unions and societies and trade societies and all that. But there's so much in the news regarding expanding your coverage. But I would like to see those dreams achieved.
Okay, I've got another cancer question for you before we end. Can you give? I will ask you. There are two back to back, but first one, can you give 3 main guides that people should check out for? Just summary that they should take away from here now, and be able to ensure people who are living, going through, or caring for cancer patients. Very specific, living with it, going through it, or caring for those that, because that is at least if I'm very up to date with a lot of people that come on our platforms. We have quite a few on this platform at present.
Okay, so first,
first
I'd like us to just be a little bit more self-aware of things about our bodies, especially ranging from rest, if you need to sleep more, do more exercise and all that, to other sort of changes like, your stool consistency. The stool is a little bit harder now. The stool is getting pointy now. The stool has changed in color now. And not just feel. I know how for someone like me, how the daily routine tends to take priority over the extra routine steps there to try and address those changes we are noticing. But sometimes you notice that some people's stories, because the body was talking about some of these things in some ways. But so trying to how to focus, how to prioritize ourselves too. But sometimes this daily routine is not even we're not even being selfish. The daily routine is about our family members, work, and some other things that we are pushing ourselves out to ensure other people are happy. But sometimes that comes at the expense of us. So I'm not saying we should become more selfish. I'm just saying that let's become more self-aware and care for ourselves too, as well as we care for others. Then also guides in terms of people who are living with the disease is that um, taking as much information as you can, but not all information is helpful. Sometimes some people come, like there's a big movement in Nigeria similar to the anti-vaxxer movement, where that is discouraging people from taking their orthodox treatments against cancers. Like they're discouraging people from taking chemotherapy and radiotherapy and telling them to go and take Indian tea or Ayurveda diet or stem cells, that stem cells. And then the cancers get worse and they have to now come back and start getting orthodox treatment thereafter. So I would say taking information, but be very guided with the information you adhere to. Then also, I'll just say it's easier said than done because I'm not a person living with the disease. I just have to treat. And it's also difficult to treat sometimes because sometimes we have burnout syndromes and all that, and it's also psychologically stressing too. So I'm not saying it is, it's not easy for me to say, but I also want to say that we need to be a little bit hopeful about things and try and think positive and renew our goals and be positive about the way we go through everything that we do. And we should continue doing things like this. Like I was talking about, I noticed when in the clinic, I noticed patients that are coming for chemotherapy, they tend to share things with each other. So the person who is just getting his first chemotherapy is sitting down beside somebody who's getting his second round of chemotherapy. And sometimes I just listen in and I found out that the conversations that they're having was actually of better advice than I could have given because I'm coming from their doctor, but they are coming from each other's team. They're almost like teammates in the same team. And so more of such sharing of information and encouraging one another is to go along with help us to win this victory or win this battle against cancer.
Thank you. That's what we're doing. Let's talk about it. Let's just talk about it. Maybe if we talk about it, we'll actually make a significant difference and stop people sharing misinformation. Quick one. Is there any other question on the house before I close for today? Because I found this one quite interesting. Okay, the one thing I did say I said I wanted to ask, and that was the last one. You made a comment about the changing in stools and noticing it. I'm going to make a comment. If it's wrong, then you can correct me. But one of the things I can say, and I think anybody on the platform who has gone through or has been diagnosed with cancer will tell you that there is no sign that you have cancer. Cancer is an everyday sign. That was one thing that I did pick up. I had an everyday headache. And before I knew it, headache became cancer because the cancer was going somewhere. And a lot of people will say they didn't actually notice that they had, I've seen your hand up, I'll put you through in a minute, that they had cancer. One of the fundamental things I did notice was it was not clear, it wasn't cut out. And that's one thing I found with most people I've talked to who have gone on the cancer journey. A lot of us are, some are on the platform, some families are on the platform. We don't actually have a state, this is what happened. It's, I had a headache, or my stomach was hurting me, or my hand was hurting, something strange, and you didn't take it seriously. And by the time we knew, one of the messages that we have tried to do is say anything that is on that you've had that persists, just keeps persisting and is not going no matter what treatment, should be looked at very seriously and looked towards cancer. Am I giving the right message? And the reason I'm asking is I am not a medical practitioner. I am a survivor. I have done almost 5 years. And that is very important that people understand, because I think we keep taking advice from do this, do that. Like you said, some diets, some campaigns, don't take this, don't take that. Well, it's the same way we're doing COVID. Don't take this. Me, I will tell everybody, and I've done it on this platform. Everybody who has cancer has got cancer. Please just go and take COVID vaccine. I'm not hiding it. Just take it so you live. Me, I've done it and I've been there and I've won the t-shirt. It's not worth it. It's not worth coming back to say, oh, then sorry, this person died, because we didn't take the right counsel. Am I giving the wrong information? Because I've got one more question before we end.
So it's not wrong information, and I think it's also, you just said the same thing I said when I was talking about being self-conscious and self-aware of how your breast feels, how your stool color and all that. So if the change is now noticed and it persists, then maybe somebody we should just do something about it. And it applies. This I'm saying applies to me too, because there are patients that you when you're taking a history, and they notice blood, small specks of blood in the stool, and just felt to go. And it's a usual. It's I don't I'm trying to choose my words carefully. It's something that can easily be done, that you would see a change and wish it away or will it away. And sometimes it works, that you don't will it away and it stops. Sometimes it just persists, and it's just good to just have it checked. It's better for you to check and it's nothing than for us not to check. So that's what I mean about being self-conscious and self-aware of what your breast feels like, how your stool, how often do you go to the toilet, is there blood in it? There hasn't been blood in it all this while. There's no blood, or it has changed color. It's now dark. It's now looking like coffee or blood. And let's do something about it. So those I agree with everything that you said. It almost seems similar to what I said too, but just in a different way. Maybe
we're a survivor. You are a doctor.
Yes, exactly.
Uzo, we have. Can you unmute yourself and ask your question?
Okay. Good afternoon. It's not really a question. It's just appreciation. Yeah. I mean, I've read a number of articles and that different things, but I think sessions like this are really helpful in creating awareness. I mean, I'm one of those people who has taken my very fortunate relative good health for granted, but listening to a session like this makes me appreciate just how fortunate I am, but also that I shouldn't push my luck, especially since there are options out there for regular proactive checks and or tests and early intervention as well. So I mean, I think that's sort of really hit home for me. So I just wanted to thank you, the organizers here, for making the effort to create this awareness. Thank you.
Thank you, Zo. Thank you. Okay. Any other questions? Any comments? Any feedback? Anything? No. I want to say a very, very big thank you to everybody. Dr. Niyi, Olabumuyi, thank you very, very much for your time. It was worth us waiting for it. And considering colorectal cancer is a cause for concern, you've given us enough information to now put out a load of posters on our pages. So I'd like to say thank you for joining Common Cancer Foundation on this particular event. You can follow us on our Facebook, our Instagram, our WhatsApp, our Facebook, our Instagram, our website, and our YouTube channel. We have a YouTube channel as well. You can put in comments there, and in the next few weeks, we are intending to put up a lot of, I think this is going to benefit mainly Nigerian community, is putting out live radio jingles and television adverts on the different cancers we've covered this year. Fundamentally, Common Cancer Foundation is an awareness campaign based on experience of a family who have gone through cancer. One person that will tell you, I have a grandmother who had it, a mother who had it, and I'm here now. So sometimes when we listen, we get to know what are the likely things that can happen to any one of us and never take things for granted. So at this point in time, I'd like to thank every single one of you for coming on. Any questions, any feedback, please send it into our DM and we will talk to you. If you need any help or guidance, we do. For those who are in Nigeria, we do somehow have survivors around. So if you have or need somebody to talk to, if you let us know, we will send somebody to you or you to them and we'll connect you, because that's all we can do. Just talking to each other makes a significant difference. Getting the right guidance from the doctors makes a significant difference. So together we'll walk this walk together. Together we will fight and we will win. We have to win. Cancer survivors, please, we have to win. Can't give up. So I want to say very big thank you to everybody. Thank you, Dr. Olubunmuyi. Thank you. Our Presido is online. So I want to say thank you to our Presido. One of our directors is on. Dr. Wenga, I know he's hiding, but thank you. He's one of our directors for Common Cancer Foundation. He's hiding. He's always hiding. But
I'm walking.
You see?
I have to stay, so I'm always walking. So, but it was a great presentation. Thank you very much.
Thank you. And to my greatest shock, one of my lecturers in university is also on. Thank you, my Oga the top.
Thank you very much, Dennis. Thank you.
He actually spoke. I didn't expect him to speak, and I wasn't going to. Thank you. Thank you. Yeah. So I want to say thank you to everybody for coming on, and hopefully we'll see you soon. Towards the end of the year, we're going to do a bigger event, and we're bringing back all our speakers to come and talk again, and to be able to put a round table, maybe a bigger event in Nigeria sometime, so we can actually bring survivors, medical professionals, and the various groups together to talk about this. Let's talk about it. It's called it. Nobody uses the word cancer. It's called it. Okay? Thank you very much and have a good weekend. God bless you all. Thank you.
Thank you for having me.